Good afternoon. I'll be discussing the musculoskeletal system. And first we'll just look at what your reading assignment is. It's chapter 34 and partial on 27, and that's with the juvenile arthritis. Now let's go to the overview of the musculoskeletal system. The MS system consists of bones, muscles, joints, tendons, ligaments, connective tissue, and there's more than 200 bones. The skeletal system manufactures erythrocytes in the bone marrow and provides storage for minerals such as calcium and phosphorus. And as you look at the slide, you can see the information that's provided there. Provides structural casing or protective armor for the internal organs. Allows for voluntary movement. And children suffer from disorders of the system more frequently than adults because their bones are still growing. Locomotion problems may occur, and this may be a serious problem in children because children gain knowledge by interaction. And children usually are going to present with a specific or localized problem. There is a difference in the child and the adult as far as the skeletal system. The periosteum is stronger and tougher. It absorbs more energy before breaking and heals quicker. The epiphyseal growth plate at the end of long bones. If a fracture occurs there, it could disrupt. It also may interfere with growth of the bone and lead to serious complications such as limb length discrepancy or cessation of growth in height. And let's look at the parts of a bone. You probably remember this: the diaphysis, the epiphysis, the metaphysis. Diaphysis is the shaft of the long bone. Epiphysis is the proximal and distal ends of the long bone. It is considered the ossification center of the bone, and muscles are attached to both ends of the epiphysis. The metaphysis is a section of the long bone in which the diaphysis and epiphysis come together. It's responsible for growth until the child's adult height is attained, and this contains cartilage and produces the bone. The medullary cavity is the interior of the bone, which contains red and yellow marrow. Hematopoiesis is the production of the blood cells. It occurs in the red marrow, and the yellow marrow is the site for fat storage. Bone formation begins in the first trimester of pregnancy, and usually at that second month, and ossification is nearly complete at birth. Maturation and bone shaping continues until about 21 years of age. And I want you to be familiar with on page 1140 and figure 34.1. 34.1. Okay, musculoskeletal injuries. Which age group is at the greatest risk? Which age group do you think is at the greatest risk? Okay, because I know you already had this in class, so you know it is the older pre-adolescents and adolescents because of the higher level of athletic activity and greater body mass. Often at play and during participation in sports and recreational activities, and also trauma. Accidents and injuries may be caused by immature cognitive development, increased mobility, and immature or underdeveloped motor skills. Musculoskeletal sport injuries. Okay, sports causes a lot of injury in children, such as snowboarding, skiing, baseball, softball, skateboarding, scooter, football, bicycling. All of these can cause injuries. Most sport injuries in older children and adolescents are not skeletal, so they're not really fractures, but soft tissue injuries, which include sprains, strains, and muscle contusions. Younger children, sprains and strains are uncommon because growth plates are weaker, and the ligaments will usually separate before a ligament will tear. And we're going to talk about each one of these: sprains, strains, contusions, fractures, abrasions, dental injuries, concussions. Well, fracture is a broken bone, contusions, bruised muscle. There's damage to soft tissue, subcutaneous structures, small vessels, and the muscles, yet the integrity of the skin is not disrupted. And this is the most common of all sports injuries: contusions. Abrasions, that's just the cuts in the skin. Sprains, the stretching or tearing of ligament from injury to a joint. A mild sprain, signs and symptoms: local tenderness and minimal swelling with no instability of the joint. Moderate sprain involves partial tearing of the ligament, partial joint instability. You have immediate pain and a moderate amount of swelling and bruising. Severe sprain causes less pain than moderate sprain because pain fibers have not been stretched. Okay, in strains, stretching or tearing of either muscle or tendon from overuse, overstretching, or misuse. Mild strains, excuse me, microscopic tears in the muscle, or you get local tenderness, minimum swelling and bruising. Moderate strain, it's a larger number of muscle fibers are torn. You may hear the pop, and a small defect may be palpated when you actually start feeling the area where this occurred. Severe muscle strain, popping or snapping sound, complete with the rupture of the muscle. Severe pain, marked bruising, and loss of function with that body area. Tendon injuries, they swell, they're painful, but do not bleed because tendons are avascular. Soft tissue injuries, diagnosis is based on clinical manifestations. The x-ray may be obtained to rule out the fracture, but it's not really diagnosing the soft tissue injury. And the treatment for the soft tissue injury is RICE. And do you remember what RICE is? The R, rest. The I, ice on 30 minutes, off 15. Compression, this is with a type of elastic wrap. And elevate, and you want to elevate the body part level with or above the heart. Sometimes casting or bracing for several weeks may be needed, and sometimes surgery is needed when there's a complete tearing of the ligament. Also with the brain injury, concussions, that also, okay, with concussion, it's usually secondary to blunt injury. It can be caused by the stretching, compression, or tearing of nerve fibers near the brainstem without accompanying gross structural damage. But the pediatric concussive syndrome results from its insult to the brain stem. It occurs most often in children under 3 years of age. And usually at the time of injury, they appear stunned, and later on clammy, pale, lethargic, or also frequent episodes of vomiting. So that's going to, for nursing issues, to observe closely for signs of more serious injury. And also for IV intravenous hydration. So to assist with the prevention of these injuries, page 1142, table 34.1, risk factors are related to the type of sport and level of training intensity. Individual activities have continual risk factors such as skating, dancing, and team sports are somewhat safer. With the individual activities, there's just more training involved. So remember to do warm-ups and cool-downs to prevent strains and sprains. The equipment should fit well. You're not going to put equipment from a larger child on a smaller child. No, do not use steroids. And some signs and symptoms of anabolic steroid use: temper tantrums, personality changes, decrease in body fat, increase of skin problems such as acne, stunted growth, decreased sperm production, irreversible breast enlargement, increase in low-density lipoprotein, and a decrease in HDLs. And let's look at the fractures. This is on page 1143. The diagnosis of a fracture is based on the child's signs and symptoms, history of the injury, physical exam, and x-ray. X-rays are the most reliable method of determining if a bone is fractured, as well as the type of fracture. The goal is to promote bone healing, restore function and appearance, and return the child to their normal lifestyle as soon as possible. And the treatment is going to be for a closed or open reduction. For closed, it's the alignment of bone by manual manipulation or traction. Open reduction is surgical alignment of the bone using wires, pins, bones, screws, or plates. And there's a box I want you to look at on page 1146. And this slide is just pictures of the different types of fractures. The first one is a closed or simple fracture. The skin over the broken bone remains intact. And we're going to go across the top, and then we'll go down to the bottom of of the bones. In an open or compound fracture, the broken bone protrudes through the skin. A transverse fracture occurs at a right angle to long axis of the bone. An oblique fracture is a slanting or diagonal break across the bone. A spiral fracture is circular and twists around the bone shaft, and this is seen more in child abuse cases. A green stick fracture is a break through the periosteum and bone on one side, while the other side only bends. So just that one side is broken. The other side just bends. For the nursemaid's elbow or subluxation, it's a dislocation or a partial dislocation, and this usually happens in children who are less than 5 years of age, and it's when a child is suddenly jerked to prevent a fall, or when a child is forcibly lifted by the hand. And I'll show you a picture, and you can see how the swinging, how you could actually dislocate a joint. And for this type of fracture, a cast would be used to hold the bones immobile and offer protection. And traction is the application of a pulling force to a body part against the counter-traction pull exerted in the opposite direction. And we'll look a little bit at these two kinds of traction, skin and skeletal. And I just want to commend you all. You did a nice job on your discussion. I know I went back to listen to it and the volume was very low, but you all did you did well with that in class. For the signs and symptoms, for the dislocation is pain, immobility, a change in the normal contour of the joint or the length of the extremity. There's a discrepancy now in that length. Diagnosis, observation, the physical assessment, but X-ray is going to be your definitive mode of diagnosing the fracture. And the treatment will be closed manual reduction with the child under conscious sedation or general anesthesia, and immobilization by the splint, sling, or cast. And I want you to look at the neurovascular status on page 1150, and it's box or table 34-2, and it's giving the normal and abnormal. And the neurovascular status, that's pain, skin color, pulses, sensation, motion, skin temperature, and capillary fill. So I want you to make sure that you are familiar with those and that whole neurovascular status. The talipes equinovarus is a disorder where the foot remains in an inward or downward position. The cause is unknown, but it does have genetic predisposition. Treatment begun as soon as after birth as possible. Serial casting is the major method of non-surgical treatment, and the cast is changed every 1 to 2 weeks until correction has occurred, and it usually takes about 3 months. And if casting does not work, then surgery, and after surgery, the casting is done again. And then sometime the braces will continually to be worn to maintain that correction. And children will be seen by their pediatrician until their late teens if they actually did have a diagnosis of the talipes equinovarus. So once again, casting may be at the first day of life. The cast is changed is serial casting every 1 to 2 weeks for about 3 months. And if the casting is successful, then braces are sometimes used to maintain the correction. If casting is not, then surgery occurs, and after surgery, the casting is started again. For nursing management, post-op, your neuro checks, ice bags, elevation, analgesia. And family teaching is care with the cast, bathing, equipment, how to use the car seats, and those type of situations that you're going to make sure that the family is aware of before discharge takes place. And this is just a slide that shows the club foot. And these are just braces that's worn after the serial casting has done its correction or surgery, and then serial casting, and then the braces that's worn. And this is just a child who has some of the casting done. And this is just a review question for you. Jane's child has club foot. She asks the nurse what kind of treatment she can expect her daughter to go through, and the best response by the nurse is, and I think you all have already seen this and picked out the right answer. Of course, we know treatment will begin as soon as after birth as possible, so we know that one's not right. And it said it usually requires about 1 year. Well, treatment will continue. The child will be seen into their late teens. And of course, there is treatment. So the answer to the last one was serial casting is used as a method of treatment. The cast is changed every 1 to 2 weeks until complete correction has occurred. Scoliosis. This is on page 1164. 2 to 3% of children in the U.S. develop some degree before age 16. It's more common in girls, usually ages 10 to 16, but you usually will get a lot of the diagnosis right at around that age of 16. There's functional scoliosis. It occurs as a compensatory mechanism in children who have unequal leg lengths, and sometimes in children with ocular refractive errors that cause them to constantly tilt their head sideways, and it usually causes the C-shaped spine. Then there's structural scoliosis is idiopathic. It's a permanent curvature of the spine accompanied by damage to the vertebra. So in the assessment, unequal shoulder and hip levels, prominence of one scapula, curved spinal column, trunkal asymmetry. So that trunk area of the hip, one will be higher than the other. You're going to see the asymmetry there. And pelvic or neck tilting also can cause spinal deviation. And I know some of you had mentioned in class about carrying that backpack on one side, which started to give you that spinal curvature also. So all children less than 10 years old should be assessed at all health visits, and also school nurses have these visits done also. Sometimes these are some clues or what the person will tell you, that their bra straps are adjusted. It keeps sliding off their shoulder. It's hard to get it adjusted. Difficulty in buying jeans that actually will fit correctly. And that's that uneven iliac crest, and skirts or dresses hang unevenly. And some tools that are used to measure it would be the scoliometer. And this documents the extent of the spinal curve. And then x-rays, because you need to have that baseline description. As far as management, sometimes a lift is placed in the shoe, and children must be reminded to maintain good posture. Part of the therapy could be walking with a book on the head 10 minutes 3 times a day, or chinning themselves, bringing their chin up. It strengthens the back. And any type of exercises that stretches the spine, such as the chin-ups, sit-ups, push-ups, and swimming. Now, if the spinal curve is less than 40 degrees, usually no therapy is usually required except for close observation until the child reaches about 18 years of age. 24 to 40 degrees, it could be a body brace, traction, surgery, or a combination. But if it's greater than 45 to 50, surgery with spinal fusion or instrumentation is done. And let's look at the bracing. And on page 1166, figure 3116, you'll be able to see the different bracing. For that A, that's the standard thoracilumbosacral orthotic brace. That's for idiopathic scoliosis. And this brace may be decorated to make it more acceptable to adolescents. And B and C is the same one. It's just an anterior and posterior view. And it's a variation of the standard thoracilumbosacral orthotic brace also that fastens in the back to provide the needed support. So you want to, the first brace was the Milwaukee brace, so even though they have different names now, people still refer them to the Milwaukee brace. Make sure that they do wear this brace over a t-shirt because you don't want any type of skin breakdown. So they have a t-shirt on first, and then they'll put the brace over top of it. And I'll show you the pictures that we were talking about. And as far as some of the nursing diagnoses, I know you can already think of them without even looking at those, is impaired self-esteem and body image disturbance. And the next slide is just some different braces that you see. You can actually see the curvature of the spine, the young girl who's standing, and then you see the x-ray below, and then also the different braces that's worn. Septic arthritis on page 1157. Infection of the joint that usually develops through the bloodstream from another site of infection. It's more prevalent in the knee or hip and usually affects those weight-bearing joints. And juvenile rheumatoid arthritis, that is chapter 27. And this is page 857. There's a table 27.2 that have some different labs on it, but just make sure that you've read this material. It affects 1 in 1,000 children, slightly more common in girls. Usually peaks in 2 to 4 and 10 to 12-year-olds. The symptoms must begin when they're less than 16-year-old and last greater than 3 months. And it may present as 3 major disease courses: systemic onset, polyarticular, this is involving 5 or fewer joints, or polyarticular, and it's a simultaneous involvement of 4 or more joints. And it's the most common pediatric connective tissue disease, with arthritis being the principal manifestation. 80 to 90% of the children will outgrow and recover from having this juvenile idiopathic arthritis, but some may require medication, physical therapy, and joint replacement as the arthritis progresses into adulthood. But 80 to 90% of the children will outgrow and recover from the juvenile arthritis. And those were just the 3 types: the polyarticular, the polyarticular, and the systemic onset. Remember, the polyarticular, that is simultaneous involvement of 4 or more joints. The polyarticular is involving 5 or fewer joints. And let's look at some of the symptoms. Fever, a rash, and that's a salmon pink, and it's usually seen more commonly the late afternoon, early evening. Arthritis, fatigue, or just being tired. And you have the persistent joint swelling and stiffness that is typically worse in the mornings. And the diagnosis is going to come from your history and physical. And remember, the onset is before age 16 and has to last at least greater than 3 months. This one says arthritis for at least 6 weeks duration. Exclusion of any other conditions and radiology. And before we look at the nursing diagnosis, what would you think some are? Go ahead and shout them out. One that I have is the self-care deficit. I'm sure you all came up with that one, and a few more. Some of the therapeutic management will be exercise, rest, medication, nutrition. The heat application reduces, also will help to reduce pain and swelling in the joints and increase comfort and movement. Warm water soaks 20 to 30 minutes, and also the paraffin, which is the wax soaks. That's real helpful for the wrist and the fingers. Some exercise, daily range of motion, and Simon says where they're able to actually follow you. Swimming, walking, okay, no running, jumping, kicking, etc. Anything that puts strain on the joint. And of course the children will tire easily, so they may need to have a shortened school day. Nutrition, you want to maintain a healthy body weight. If the child is obese, you want to start on a weight loss program. Low fat, low sodium, and make sure they're taking their calcium since they're not bearing a lot of weight on those joints. We want to make sure the calcium intake is appropriate. Okay, medication. We want to decrease the inflammation, so you have your NSAIDs there, the non-steroidal. Decrease inflammation and also fever control. You want to be careful with the aspirin since it is linked to the Rise syndrome in children exposed to the flu virus. So do not give if a child has been exposed to the virus. For muscular dystrophy, a group of progressive degenerative inherited diseases causing wasting of the muscles, and the most common type is the Duchenne. Muscular dystrophy, that's on page 1161. And this is the Galper sign, is the pelvic and the trunk muscles are weak. So the child and it's just two sets here showing the different movements. The child with muscular dystrophy must use a series of maneuvers to rise from a sitting or lying position. And there's three types: the congenital, muscle weakness dystrophy, autosomal dominant trait. And this is the muscle weakness, but if this is diagnosed, this child can usually live into adulthood. It will not shorten the lifespan. Then the fascioscapulohumeral muscular dystrophy, and then the pseudohypertrophic muscular dystrophy, that's Duchenne's, and that's what we'll be discussing more so. But the fascioscapulohumeral is slow progression. Autosomal dominant muscles of the face and shoulder are affected first. Then the abdomen, feet, upper arms, pelvic area, lower arms, half are able to walk their entire life. And then the pseudohypertrophic muscular dystrophy, Duchenne's disease, absence of the muscle protein, dystrophin, which appears to play a role in supporting the structure of the muscle fibers, and enlargement of muscles caused by an overgrowth of fatty and fibrous tissues. And this is the most common type of MD. So you will see large calf muscles and that sort of thing, but it is not really the muscle. It's just caused by an overgrowth of fatty and fibrous tissues. And it's an inherited X-linked recessive trait from the males. At the age of 2 to 4 years, the pelvic muscles weaken. The child will have difficulty climbing, running, riding a bike, and they will develop a waddling gait. You'll notice at 5 to 6 years, the Gower sign, and those are those maneuvers used to getting from that lying or sitting position to a standing position. There is, for treatment, is supportive. There is no cure. The goal management is to provide support and prevent complications. Usually, this child's lifespan is late teens, early 20s. Nursing management. Activities such as swimming or water exercises are often recommended as a way to keep muscle tone and to promote mobility without causing an undue stress on the muscles. You want a diet that's high in fluids, fiber, fresh fruits and vegetables. You will have to have a bowel regimen and stool softeners to prevent constipation. Respiratory therapy to maintain pulmonary function, and genetic counseling. Hip dysplasia, and it's due to a combination of environmental such as breech position and genetic factors. The assessment is Ortolani's, and I'll show you the next slide in a minute, sign or maneuvers. The treatment, you're going to try to position the hip into a flex abducted position to place head of the femur against the acetabulum and cause it to deepen its contour by the pressure to go back into the socket. And surgery will have to occur if you're not able to keep the femur against the acetabulum. And then also splints. And I'll show you this slide where you can see, and this is figure 3111, but signs of developmental dysplasia of the hip. That first one, you can see the asymmetry of the gluteal and thigh folds with shortening of the thigh, and you can see where the arrows are pointing. And B, limited hip abduction, where you can see how that leg is not abducting, as seen in the flexion. This is the Ortolani test. And C, again, apparent shortening of the femur, as indicated by the level of the knees. And D is the Ortolani test with the femoral head moving in and out of the acetabulum. And this is usually seen in infants 1 to 2 months old. And E is a positive Trendelenburg sign with lordosis. That's if child is weight bearing. And you can see how that length is with the iliac crest in the hip area. So a treatment for this is the Pavlik harness, and look on page 1160, that's figure 3410, and also 1148 with Bryant's traction. So if the child is less than 3 months, the Pavlik harness abduction device, and it's worn 24 hours a day for 3 to 4 months. So that's some teaching that you're going to have to do with the parents, especially for discharge. You're going to want to see some return demonstrations, how they're going to be changing diapers, how they're going to be bonding and just interacting with the child. And if that is unsuccessful, then the skin traction and surgery. And if the child is greater than 3 months, so skin traction and surgery is done. The Pavlik harness is just worn for those less than 3 months. Diet, you want to a high fiber, and also padding around the casting if casting is done. And look in your book for the spica cast and for that cast care. I want you to look at the cast care. There was a box for that I wanted you to pay attention to. And on child abuse, remember the fracture. It's usually that spiral fracture that you usually see in the musculoskeletal injuries for child abuse. But look on page 1146, and there's some more information about that for you. So there's 4 categories: physical abuse, sexual abuse, psychological, and neglect. For review, all of the following factors are strongly suggestive of abuse in the child except, multiple or depressed skull fractures, frequent ear infections, multiple fractures in various stages of healing, spiral fracture of the humerus. Which one do you think it is? All of the following are strongly suggestive of abuse in the child except. So all of these except one of them is suggestive of abuse. And yes, you've got it right, the ear infections. So look at osteomyelitis on page 1156. Infection of the bone caused by a bacterial, fungal, or viral microorganism. And for diagnosis, bone aspiration, positive blood, or tissue culture. Child's complaint of pain or tenderness over infected bone, and the labs. And you would get the a WBC, white blood cell. For the WBC, your book actually says a CBC, but the WBC would be elevated. Also, a CRP, which is the C-reactive protein test, and an ESR, the erythrocyte sedimentation rate. And the C-reactive protein and ESR are usually elevated, which indicates the presence of an inflammatory process. So you would, the treatment would be antibiotics, but before you would start the antibiotics, you would make sure that you would get blood cultures first, and then after the blood cultures, then antibiotics. First is given IV, then PO, then splinting of the limb, and possibly surgery. So nursing management, analgesics for the pain, splint traction, any type of assistive devices that the child will need. You're going to make sure that you're doing the neurovascular. Remember what that status was on those different things with pain, temperature, and etc. And skin assessments performed at least once every shift. And education on the medicine that's going to be given, such as the antibiotics. And those are activities that you all assisted with in class. So I want you to look back at those, the different type of skin tractions, skeletal traction, know the difference between the skin and skeletal, your neurovascular assessment, cast care, sports injuries and treatments, because those sports injuries are basically going to be more of soft tissue injuries. The Pavlik harness, which is for the children under less than 3 months, and the juvenile idiopathic arthritis. Be familiar with those and those tables that I had discussed with you and have previously mentioned. Okay, just wanted to look at osteomyelitis again, and the clinical manifestations again: constant bone pain, localized and increases with movement, so you want to restrict that movement. It's also fever, swelling, heat, and redness. And so you have that antibiotic therapy, which is going to be after you get your blood cultures, and then begin the antibiotics. IV, then PO. You're going to splint that limb. You do want to keep that that limb restricted movement, and surgery also. All right, thank you for your time with the musculoskeletal and pediatric alterations. Study hard. I know you're going to do well on your test. Take care. Have a wonderful evening.